And good morning, afternoon, or evening, everybody, and thank you for joining today's Endo-ERN webinar, which is entitled An Overview of the Clinical Trials in Prader-Willi Syndrome. I'm pleased to introduce you today to our speaker, who is Maite Taubert from the French Reference Center for Prader-Willi Syndrome, Children's Hospital, and also member of Endo-ERN, Toulouse, France.
To give this webinar about clinical trials in Prader-Willi syndrome, because there are many new trials, and I think that it was interesting for people that care for Prader-Willi syndrome patients to be aware of that. I'm not sure it works. Okay, so now I can use the slides. So here are my disclosures and affiliations. So first, a short introduction on Prader-Willi syndrome. Prader-Willi syndrome is a neurodevelopmental genetic disorder due to loss of expression of paternal inherited maternal imprinting allele in the chromosome 15, Q11, Q13. So it's a very complex genetic region. Nowadays, the newborns presenting with 50% with paternal deletion and almost 50% with maternal disomy, which is a change from the previous time, with deletion was the most common. Prader-Willi syndrome is a neurodevelopmental disorder with a very specific trajectory with 3 dimensions: nutritional, endocrine, and metabolism and behavior. As every people who care for Prader-Willi knows, it started with hypotonia at birth with sucking difficulties, which is close to an anorexic state, and then switch for an excessive weight gain, and then driving obesity with hypophagia and food addiction. Regarding the behavior trajectory, infants present at birth poor parent-infant interactions, and then when adults, they display intellectual disability, learning disabilities, poor social skills, emotional dysregulation. And of course, they also present a trajectory of endocrine dysfunction with hypothalamic disorder and other specific features which I will develop in the next slides. The hypothalamus controls endocrine and metabolic function, appetite regulation, emotion, and behavior, and is linked to the autonomic nervous system. Therefore, impaired development and function of the hypothalamus explain most of the typical features of Prader-Willi syndrome: endocrine and metabolic disorders, such growth hormone deficiency, hypogonadism, hypothyroidism, corticotropin deficit, premature puberty, and sometimes precocious puberty, diabetes. It also explains eating disorders and impaired appetite regulation, with increased ghrelin levels and increased oxytocin levels with the defect of implementation of the oxytocin neurons. Hypothalamus also drives behavior troubles, emotions, addictions, and social disabilities. And hypothalamus is very linked to dysautonomia presented by this patient regarding temperature dysregulation, hydroelectrolytic disorders, gastrointestinal problems, and cardiovascular dysregulation. We recently published with my colleague Charlotte Oibay in the Lancet Diabetes and Endocrinology that endocrine disorders in Prader-Willi syndrome is a model to understand and treat hypothalamic dysfunction. It's a very complex disorder. Besides brain dysfunction and hypothalamic dysfunction, they're presented with many comorbidities. In the left-hand side, respiratory problems, cardiovascular disorders, GI problems, orthopedic problems, but also in the right-hand side, ophthalmologic issues, poor oral skills and swallowing problem with dysphagia, metabolic disorders, which I already developed, and urogenital problems. and also skin problems. So it's a very complex multi-systemic disorder. The most important feature is hyperphagia. What is really hyperphagia in Prader-Willi syndrome? It comprises obsession with food and food-related items, foraging and storing, stealing food, craving for food, food impulsivity, and these patients display some specific behavior before and during meals with agitation and abnormal behaviors, sometimes excessive cleaning of the dishes, cramps, over-preoccupation with others. And they eat either excessively slowly or excessively rapid with risk of choking and aspiration. And they also have excessive quantities of food, but also excess drinking intake. Hyperphagia in Prader-Willi syndrome might be linked with addiction for food, and we recently published a paper comparing addiction with Prader-Willi syndrome. But mirroring this hyperphagia behavior, they also display non-food related behavior, which are very specific for these people. They display sometimes other addictions, smoking particularly, objects collections, global impulsivity, thinking rigidity with difficulty to change mind, not only for food, disruptive behavior, perseverations, repetitions, rituals, and difficulty to evaluate quantities. We can imagine that day-to-day consequences of hyperphagia are very important, and that the distress for patients and their caregivers is lifelong, considering that hyperphagia requires constant diet restriction, environmental controls and supervision. And of course, it's a completely modified the quality of life, social functioning, and school and work are also affected. Not only the individuals are affected, but the family and the caregivers. A very recent survey showed that the negative effect of the symptoms of Prader-Willi syndrome increases over time, and the consequences on the family also increases over time. How can we assess hyperphagia in clinical trials? So a specific questionnaire named Hyperphagia Questionnaire for Prader-Willi syndrome has been developed many years ago by Dykens and all in the US. This questionnaire has been modified for clinical trial use, and its name is HQCT, Hyperphagia Questionnaire for Clinical Trials. It comprises 9-item questionnaires completed by the caregiver. The questionnaire is divided into 3 subscores: the behavior, the drive, and the severity of the hyperphagia. And there are 5 alternative structure answers to each question. And it uses a 2-week recall window. How can we assess behavior in individual PWS, particularly in a clinical trial? So the Foundation for Prader-Willi Research recently developed a Prader-Willi syndrome profile. It comprises 52-item questionnaire specific to Prader-Willi, also completed by the caregiver. This questionnaire has also been developed by the team of Elizabeth Dykens and Elizabeth Roof. And it is designed to assess non-food related behavior. And each question is answered not true, sometimes true, or often true. And the behavioral domains which are assessed by this questionnaire are aggressive behavior, anxiety, rigidity, irritability, compulsivity, depression, and disorder thinking, which really summarize the behavior that we can have in patients with Prader-Willi syndrome. Of course, we can use also other questionnaire or other evaluation that have been developed for other people with autism or with intellectual disability. And that was the case in the clinical trial that I'm going to present. Of course, in a clinical trial, body composition and metabolic complications of Prader-Willi syndrome need to be assessed. Body composition and metabolic complication, particularly evaluating circulating leptin levels, grellinemia, and hyperinsulinism. Regarding the drugs and the clinical trials, what are the issue targets by the drug and the clinical trial? Of course, endocrine dysfunction was the first, but the most important for the patients and the parents are hyperphagia items, and then behavioral features, and then sucking difficulties. But also, how can we modify the oxytocin and ghrelin dysfunction that all these people present, or most of all present? There were many drugs that have been assessed and used in Prader-Willi in the very recent past, and also now with ongoing clinical trial and future trial that will start. Many drugs focusing pathophysiology approach, but other using drugs that was used previously for other diseases. But of course, the use of a drug is not the only solution for the people, and the use of the drug is on top of all the optimal care that they need, meaning early diagnosis, family support, control of food access and physical activity, treatment of endocrine disorders, treatment of comorbidities such as scoliosis, orchidopexy, other respiratory and cardiovascular comorbidities, re-education, communication skills and emotion recognition, and also using psychotropic treatments when needed. I will start with oxytocin in Prader-Willi syndrome because I'm working on these clinical trials for more than 10 years now. And oxytocin has been used at all ages, in infants, in children, and in adults. Why can we use oxytocin in Prader-Willi syndrome? The first study was published in 1995 by Dix Fab. He showed that the paraventricular nucleus, which produces oxytocin, was decreased regarding the number of cells and the size of the neurons. It's really specific to oxytocin because vasopressin neurons were normal with immunohistology. Interestingly, the mouse model obtained by inactivating the nectin gene or by inactivating the MAGEL2 gene drive also abnormalities in the oxytocin neurons of the paraventricular nucleus of the hypothalamus. Therefore, it seems that oxytocin system is impaired in the paraventricular nucleus of patients with Prader-Willi syndrome and in mice models. Therefore, the team of Florida, Jen Miller and collaborators showed that unexpectedly, plasma oxytocin levels were increased in patients with Prader-Willi syndrome, possibly by correcting the defect of oxytocin system. It is the hypothesis that everybody shares now. And this increased oxytocin level was also demonstrated in mice model. What did you have in preclinical data? In the MAGEL2 cow mice, it has been shown by the team of Françoise Muscatelli in Marseille, in Lumini in France, that a single injection of oxytocin given during the first 5 hours of life can rescue completely the death, the early lethality in this mice, but also rescue sucking. And this effect was long-lasting because adults mice have increased memory and learning skills, which are comparable to the normal mice. We will start for the publications on clinical of intranasal oxytocin treatment in patients with Prader-Willi syndrome. There are 2 slides summarizing the data. The first one was published by our team in 2011 in adults using a single dose in a placebo-controlled trial and showing that after a single dose of oxytocin, patients improved in behavior, increased trust in others, decreased disruptive behavior, and decreased sadness tendencies. After this trial, the team of Australia published very different results. This study was a crossover study with a duration of treatment of 8 weeks by period, including adolescents and young adults, with dose very high compared to the dose that we have been using previously, with high doses of 35 units twice a day and 40 units twice a day. They did not show any significant effect, while the patients receiving high dose have higher Temper-Haupers, which is not, of course, the thing that we want to observe. But the low dose seems to decrease Temper-Haupers, but does not reach significance. The team of the Netherlands, Renske Kuppen and the team of Anita Ook and colleague, also did a crossover study, 4 weeks duration of treatment of period, including 25 children and adolescents, and they observed a positive effect on behavior and food-related behavior in the youngest children, but no effects on the oldest children, older children above 11 years. In all the study, oxytocin was well tolerated without any side effects. In the US, Jennifer Miller showed the results and published the results of a double-blind study, 5 days of oxytocin or placebo treatment in 24 children with 16 units per day. The drug was well tolerated, but there was not significant change, but interesting signal and improvement in the behavioral, socialization, anxiety, and appetite endpoints. We published in 2017 a study on infants using 3 steps of oxytocin. The first 6 children received 4 units every other day. The 6 other children received 4 units daily, and the 6 last children received 4 units twice daily. We demonstrated an excellent tolerance of the drug in infants less than 6 months of life, and all of them improved sucking and swallowing. They also improved mother and infant interactions, and they modify significantly acylated ghrelin and connectivity of the right superior orbital frontal cortex region, which is very interesting because this region is particularly interesting in food and appetite regulation and social regulation. We did not observe difference between the 3 doses used. And this year, 2 new publications by Hollander Group in the US, showing that in 33 children using 16 units twice a day, he did not observe changes with oxytocin. Conversely, children receiving placebo did better than those who received oxytocin. And the team from the Netherlands published a new study in 26 children, showing that there is no effect on hyperphagia in the total group. But they observed significant effects on behavior in boys, and the effects are better in the group with deletion. It was the first study where we observed a difference between the 2 major genetic subtypes in Prader-Willi syndrome and a sex ratio in the effect of oxytocin. We know that there are many studies already terminated but not published, 3 of our team and another for the group of Hollander in the US, including adults for us and children for 3 other studies. So the most interesting study that I want you to talk particularly is the long-term follow-up of those infants that we treated before 6 months of life, that we were able to follow and compare with untreated children. So the effects, the long-lasting effect of oxytocin were very interesting, particularly in socialization, in modification of biological markers, and in behavior. So we are writing the manuscript, and I think it would be very interesting to look at this paper. We also started last year in 2020 in the pandemic situation, the study that we want to continue on infants, including 48 infants up to 3 months, with a 4 units administration of oxytocin and studying of course safety and the effect on oral skills, social skills, and interactions. After oxytocin, another drug which is interesting regarding the pathophysiological effects is the carbetocin. I'm sorry, carbetocin is an oxytocin analog. Compared to oxytocin, it is said that carbetocin only binds to the oxytocin receptor and not to the arginine vasopressin receptor at the doses used in clinic. So the carbetocin was first produced by Ferring, and then for the Prader-Willi patients by Levotherapeutics. So a phase 2 randomized double-blind placebo control was published on 37 children, and another study was ongoing. The recruitment was stopped. The first publication have been presented, and they observed statistical significance with a low dose and not with the higher dose on the hyperphagia questionnaire score. There is also a clinical global impression of change and anxiety, which was shown to be significant on carbetocin treatment, and the other endpoints were not significant. Carbetocin was well tolerated. It was also administered intranasally 3 times a day, and 130 patients were included. The recruitment was stopped during the pandemic situation. I want to focus also on another hormone which is target for clinical trials in Prader-Willi syndrome. These drugs are ghrelin analogs. Why using ghrelin analogs in Prader-Willi syndrome? The reason is that hyperghrelinemia is observed at all ages in Prader-Willi syndrome. Many publications have been done. There is a relative deficit of unacylghrelin in PWS and an increase of acylghrelin. So acylghrelin is a hunger hormone. It's the form that increases appetite and have also metabolic effects. What we can see on the left-hand side in blue here, that in patients with Prader-Willi compared to controls in green, there is higher acylghrelin and also high unacylghrelin. But when you make the ratio, there is a relative deficit of unacylghrelin. What you can see here in controls, that unacylghrelin is higher than acylghrelin in controls. We can see here also that in obese people, there is a comparable levels of acylghrelin and unacylghrelin, but the levels of ghrelin were lower than those observed in the control. And interestingly, the ratio acylghrelin to unacylghrelin is modified when hyperphagia starts. So the question was, can we supplement with an acylghrelin and treat the hyperphagia on Prader-Willi syndrome? There was a first study with the first unacylghrelin analog, the AZP-531, which is a cyclic form, which has the same effect than the natural unacylghrelin. The first study was published in 2018. It was a phase 2A double-blind study, European study in 4 countries, with 47 patients included. The drug was well tolerated during 14 days, and a significant improvement on the mean total score of hyperphagia questionnaire was found comparing to baseline. And the highest reduction was observed in the highest hyperphagia score, so the most severe people seem to respond better. There was also significant reduction in waist circumference and fat mass. Therefore, the Alizé Pharma who developed the AZP-531, they sent this drug to Endo-Therapeutics, and levodopa, the name of this compound, was afterwards used in a phase 2B double-blind study, an international study, including many countries, with a 3 months core phase, in which 158 patients were included. This study did not meet its primary outcome measurement, which was to compare hyperphagia score between placebo and the treatment group. And as a whole, there was not significant difference. But positive results were observed in some patients, particularly in children and in obese patients. Unfortunately, in April 2020, when the statistical analyses have been presented, Milendo announced discontinuation of the levoleucide program because of this negative result. There was another drug targeting the ghrelin system, how to decrease acylghrelin in patients with Prader-Willi syndrome, where if you target the enzyme, the ghrelin or acyltransferase, if you decrease this activity with a specific inhibitor, we can decrease acylghrelin and then perhaps modify the appetite of this patient. That was done by the GLWL company. The phase 2 study, double-blind RCT study. 19 patients were included with a mean age of 22 years, and the original estimated was 34. The study was stopped and the results were unpublished. The primary endpoint was the same, targeting hyperphagia score. It was 59 in the treatment group versus 40.7 in the placebo group. So no significant change and no significant effect of the hyperphagia score on 19 patients. The safety was good in the group comparable to placebo. The PK was also good with no difference, but the publication is not yet possible to see. What about the other clinical trials in Prader-Willi syndrome? I think one of the very interesting drug is the diazoxide controlled release, which is an analog of the diazoxide, which is very interesting because doses are lower than the diazoxide routinely used in hyperinsulinemic patients. Hyperinsulinemic patients. So the first study was made by Essentially, and the second study was made by the Soleno in the US. They included 127 patients from 4 years to adulthood. The primary endpoint was hyperphagia total score after 3 months of treatment. So unfortunately, the primary endpoint was not achieved because there was not significant difference in the HQ-CT. But when regarding the more severe patients with the HQ-CT above 22, the difference between the treatment group and the placebo group was significant. More interestingly, there was significant changes in the CGI improvement, the reduction of body fat mass, and a reduction in acylghrelin in the treated group versus the placebo group. The safety profile of the DCCR is good and comparable to what was expected with this drug. And it was not published yet. And the Soleno group decided to make a 6 months label extension with a very interesting effect and additional effect on the hyperphagia score and the reduction of body fat mass. What are the other clinical trials ongoing? We will start with the liraglutide study, which was stopped, and the manuscript is in preparation. The Novo Nordisk group made an international study with liraglutide, which is a GLP-1 receptor agonist. They decided to work on children, first in adolescents, the phase A, and also in children, the phase B. And the primary outcome was not hyperphagia score, but the BMI and change in body mass index. Unfortunately, there was not significant differences regarding BMI and change in BMI, both in children and adolescents. And there was not significant difference in the percentage of patients with a loss of more 5% weight or BMI. Interestingly, in the adolescent group, there was a significant change in the HQ-CT, particularly the driver score of the HQ-CT, which is of interest, of course. What we can see in the waterfall plot is that some patients seems to benefit from this treatment, and particularly we had a patient who have a very good effect on liraglutide. But the group, the analysis of the group did not show any significant results. There was an ongoing study with setmelanotide provided by Rhythm Pharmaceutical. It's a MC4 receptor agonist, subcutaneous used weekly. So they made a phase 2 completed in 2016, and another study I think is planned or ongoing. I do not have the information, and we don't have the result of the study. You probably know that setmelanotide is very useful on some very rare mutation of POMC or MC4 receptor. Another drug by Saniona using tesofensine plus metoprolol, which is a serotonin, norepinephrine, dopamine reuptake inhibitor combined with a beta blocker to prevent the tachycardia. So they made a first study, a phase 2A completed, not yet published, with a small number of patients, 18 patients, adults, with a primary outcome of body weight. And they are planning to make this year a new phase 2B, a new phase 3, including more than 100 patients. It is probably interesting to look at this particular drug because the reuptake inhibitor of all these neurotransmitters can be interesting to see in patients with Prader-Willi syndrome. The endocannabinoid system, which control appetite regulation and also control anxiety, of course, can be a possible treatment for Prader-Willi patients. First, the cannabidiol, which is a new drug now, more known in some particular rare disorders, was developed by Insys Therapeutics. The phase 2 was completed and unpublished yet on children from 8 to 17 years. 7 patients were included. The original estimated of enrollment was 66. The primary outcome was hyperphagia questionnaire, and secondary outcome the following here. We did not hear about the results of this trial, but another endocannabinoid was developed by the GY Pharmaceutical in the US with cannabidivarin CBDV. It is an ongoing clinical trial, phase 2, double-blind, including children and adults. 26 patients were included, and the recruitment is still active. And the primary outcome was not the hyperphagia questionnaire, but the ABC1 aberrant behavior checklist irritability scale. So this drug focused more the behavior issues of patients with Prader-Willi syndrome. I just want to focus on 2 other clinical trials and drugs which can be very helpful in Prader-Willi. The pitolisant, which is an histamine H3 receptor antagonist, which increases brain histaminergic neurons. It was developed for treating excessive daytime sleepiness and cataplexia, which of course is one of the features observed in Prader-Willi syndrome. So there are, I think, 2 or 3 publications on clinical cases with pitolisant treatment in patients with Prader-Willi syndrome. But now it is a phase 2 double-blind study comparing pitolisant to placebo at 2 doses in children and adults with Prader-Willi syndrome. 60 patients were planned to include, and it is an ongoing study with still active recruitment. The treatment duration is 11 weeks, followed by an open label extension. And the primary endpoint will be excessive daytime sleepiness with mean latency test measurements, and also the clinical symptoms, behavior, psychomotor function, and attention. I think it can be interesting to look at the results, because excessive daytime sleepiness does not respond always to modafinil, and cataplexia associated or not associated to narcolepsy is a very difficult feature to treat on Prader-Willi syndrome. And I want to finish with the topiramate. Topiramate is an anti-epileptic drug that can be used as a mood stabilizer and anti-impulsive treatment. In France, we decided to make a study, including children and adults. 69 patients were included. The mean age was 23.9 years. The duration were 5 weeks with slowly increasing dosing. And the primary endpoint was the CGI improvement. We did not observe any significant improvement on topiramate group versus placebo, but we observe a significant effect in hyperphagia. The behavior and the severity scale of the HQCT were significantly improved in the topiramate group versus placebo. We observed a significant dose effect. The tolerance was good, but some fatigue can be observed in some patients. And we also observe a significant effect with time. This study was published last year, and you have also here the link to go to the publication. To finish the review on clinical trial in Prader-Willi syndrome, I want to focus on some discussion, and we can discuss some points with the participants. We see that many drugs, some with pathophysiological impact, some with non-pathophysiological impact are developed. It is a little bit complex because it's a rare disorder. So some of the patients participated in many clinical trials, which can be good, of course, for them. But from an ethical point of view, it is difficult to make a patient participating to many trials with different drugs. The second point that I want to discuss is a placebo effect, which is observed not only in the Prader-Willi group of patients, but very frequently observed in patients with intellectual deficiency. It is also a study effect. The fact to participate to a study is probably very important for this patient, and particularly in the liraglutide study, we observed a very strong study effect with a BMI stabilization during a year in the placebo group, which is very difficult to achieve when these patients do not participate to a study. So the study effect, together with the placebo effect, is a very challenging issue that we have to work on it. And regarding the study design, the crossover trial, which is the crossover design, which is a very good design, is not, to me, the good way to work on a drug which can have lasting effects on long-term effect, because the washing period is difficult to determine, and probably there is not a washing period in this case, for example, for oxytocin. I really do think that the crossover trial is not a good one to make studies on oxytocin, for example. And of course, the endpoints and the tools that we have to measure changes on the hyperphagia and on the behavior of Prader-Willi syndrome is a very challenging issue. It's very difficult because hyperphagia can be, the HQCT can be modified by the environment. For instance, in the pandemic situation, we observed changes during the quarantine. So people are more anxious, and so the parents also are, and the caregivers are more anxious, and so the trial is not so easy to do in this situation. And we need to have some tools to focus on the particular profile of Prader-Willi syndrome. I think that the 52-item questionnaire on assessment of Prader-Willi profile is a good one, and we need to have more information on it. So finally, what would be the best drug for this patient? I think that the one which allows food autonomy and increase well-being of the patient may be the best drug for these patients. And until now, we cannot say that we have this drug, but we have to continue to make this trial and to have results to share. It's difficult to have publication at a good time, and as you observed, like me, many studies are terminated but not published. So we have also a challenge on it. And for this last slide, I want to thank first my very nice team who worked with me for many times. And I want to thank all the persons that are working with me. And particularly in Toulouse, the Hospital of Toulouse and the OT4B startup that helped me for the oxytocin trials.
Interesting that you mentioned placebo effect in your conclusions. Do you think we could make more use of this placebo effect? Should we do a study with focus on placebo?
Why not? No, I think the placebo effect is, of course, it's named placebo, but I think it's a study effect. The fact that these people are in the study, are frequently followed, increase, the investment of the caregivers, the motivation of the patients. So it's of course it's very good, but I'm not sure that the placebo effect has a long-lasting effect. What that says is that we probably need to follow them very frequently, as we do in a study. We probably need to assess them with some questionnaires, some discussions than we do in routine care. But it also, of course, depends on the number of carers that can do that. But it's probably the case. The question is, do you think using the hyperphagia questionnaire is the correct outcome measure in these trials? It's a question, thank you for this question. It's a question that we wrote many times. Of course, the focusing on hyperphagia is a need, because it's a first point that parents put on the range when we ask them to categorize what is the number one problem. Of course, the number one problem is hyperphagia. So we need to have a tool. Is this HQ-CT a good tool? To me, it's a good tool because we can capture the behavior, but we cannot capture everything. For instance, there is no question on the meal. We cannot capture the patient before and during the meal, which is a need, I think. And when you repeat it, frequently, I think the caregivers or the parents are used to it, and so I'm not sure that they respond. The term correctly is not a good term, but I don't think it is adequate to repeat it. So it's a real problem. Nevertheless, when we see that the most severe people with the most severe HQ-CT benefit from some drugs, I think it is something that we need to take into account. So it's not the best one, but it's the only one that we have. We probably have to develop other tools regarding the knee and so on. There is another question from Anita. Do you think that the combi of medications might increase the effect? It's a good point, Anita. I think that we will have to combine, because the drugs act on different pathways, and perhaps in this particular severe disorder, we will need to target different pathways and to complement them. Christina, could you please tell us something about growth hormone treatment in patients, advantage versus disadvantage? What about the age GH treatment should start? Should GH treatment start in early infancy? Okay, so I didn't talk about GH because it's not a clinical trial anymore. It's a routine use. So in our country and in many other countries, and we wrote that in the paper with the first author, Sherry Deal, we think that we may start as early as possible. When the diagnosis is made, we can start in infant. In France, we start after 5 months, but we can start early. I think that other country, perhaps Anita can say that, but the other in the US, they started, as soon as possible after the diagnosis. So growth hormone can be started at 2 or 3 months. I think there is a publication in 2017 which I participated in, showing that there is a true growth hormone deficiency because of the decrease of the proconvertase 1 effect. So the maturation of the growth hormone releasing hormone is not sufficient, and then there is a deficit of growth hormone from the hypothalamic origin. So I think we need to treat it very early. It's a substitution treatment. It was interesting. We decided in the group to make this overview. Of course, perhaps people are more interested in other more clinical situation, more genetic issues, but I think that it is something that we have to have in mind. All the studies and the ethical aspect that also has to be thought, because we cannot make patients, going from a trial to another, because what could be the following of this patient? It is a little bit complicated. Of course, we have to do our best to treat the patient, to study new drugs, but it is something very important to have in mind, and particularly the agency needs to have it in mind, not asking for many patients to be included in the study.